we are talking about the antitussives, mucolytics, and expectorant agents. Now, when you look at the way the respiratory system is, because these drugs are going to be used part of the respiratory system and also the GI on top. So the respiratory tract has got cilia and it has got a cough reflex. These two mechanisms are important to protect us. So the mucus and the cilia that makes up the mucociliary clearance, which ensures optimum tracheobronchial clearance by forming sputum. Okay, and then the cough reflex is going to exhale, remove the sputum out. So let's say there is dust. That dust is going to be trapped by the mucus, and then cilia will allow it the mucus also to start moving to be removed. But not all of it might end up being removed. The cough reflex is going to come in so that we can now push out everything. So that is what happens. Coughing can either be productive or non-productive. If we say productive cough, we mean in this cough you have got also sputum. Non-productive cough is a dry cough. So when you're talking about also the drugs that you are going to be able to use to treat cough, for a productive cough where there is a sputum, you are going to use the mucolytics, mucus, lytic to break down, so breaking down the mucus, and the expectorants. For a non-productive cough or a dry cough, you are going to use antitussive agents, those drugs that will be able to suppress the cough, antitussive agents. Okay, so this is just showing us examples. So for productive cough, expectorants and mucolytics. Examples of mucolytics, those that breaks down mucus, you have got any acetylcysteine, bromhexine, and then palmozyme. For the dry cough, you use the antitussives. There are some antitussives that act peripherally, and then others are central acting. So for the mucolytics, these are medications that help you to cough up phlegm or this sputum by thinning mucus and making it less sticky. So mucus lytic, breaking it down. So basically trying to break down the mucus, making it thin and making it less sticky. Thick secretions can be a problem in patients that have got obstructive lung disease. For example, someone has got COPD, like emphysema and chronic bronchitis or asthma. Already they have difficulties in breathing, and that mucus also is going to even worsen it because it's also causing more obstruction. So mucolytics, these agents will be able to loosen the secretions so that they are not so thick. And drugs that alter the biophysical quality of sputum are the ones we are calling as mucolytics. Okay, they will be able to alter the biophysical quality of sputum so that it can be easily exhaled by the mucociliary clearance or less intense by coughing. So basically, looking at the biophysical, you are trying to thin it. The mechanism of action of mucolytic agents: number one, they reduce viscoelasticity by increasing water content. If you remember mucus the way it is, if you increase water content in it, it means that it is going to be now thinner. Example of the agents that do that, you have got hypertonic saline and sodium bicarbonate. And then also to reduce adhesiveness, the ability to like attach to the surfaces in the respiratory tract, you have got steam. Like if you inhale steam, it can do that. Also splitting disulfide bond so that the mucus becomes less viscous. Viscosity is that thickness that fluids have so that they fail to flow. So when you get to split these disulfide bonds, you make this fluid to be able to flow. An example is N-acetylcysteine. That's the way it works. And then some of them works by synthesizing serous mucus. Serous has got more of the water, okay, than mucoid only. So it is a secretolytic plus activate ciliary clearance and transport. Examples are to work by making this serous mucus and then being able to activate the cilia and transport is bromohexine and abroxol. And then there's also cleavage of extracellular bacterial DNA that contributes to viscosity of sputum in case of infection. So I've got an example of ARA HDNase. Okay, so basically breaking down the bacterial DNA that makes the sputum viscous. An example of the rHDNase is palmozyme. These are enzymes. So let's talk about some of these ones. We can see acetyl N-acetylcysteine, the one which was breaking down. How will you remember? Remember the amino acids. You have got two amino acids that have got sulfur in them, methionine and cysteine. Okay, so we're breaking down disulfide bonds, the sulfur, using the N-acetylcysteine. So just remember the cysteine will work on the sulfide bonds because the cysteine itself is the one of the two amino acids that contains the sulfur. So N-acetylcysteine will decrease hypersecretion and be able to liquefy pulmonary secretions to make it more solid, I mean more liquid. So there is little evidence that inhaled acetylcysteine is more effective than adequate hydration for thinning or increasing the clearance of secretion. In other words, taking water, a lot of water, when someone has got this cough, okay, a productive cough or mucus, is way better. It's actually going to be able to thin the mucus and then it will also help in that cough. So there's no evidence that when you take the acetylcysteine is going to act better than you just getting to hydrate more. So indications, when do we use the N-acetylcysteine? So most mucolytics are going to be used as adjuvant therapy in respiratory conditions with excessive and or thick mucus production. Someone has got COPD, asthma, bronchitis, you can give these mucolytics as an adjuvant. You basically add them up when you're treating the conditions so that you can end up thinning that mucus and then they'll be able to help to breathe well. Okay, and then rHDNase in particular is used in cystic fibrosis and also of benefit in respiratory infections. So that's important to know. So you can see for the other mucolytics in cystic fibrosis, they are of little benefit as mucus accumulates in lower airways and thinning of secretion may not always be beneficial since it may negatively affect certain aspects of mucus transport such as cough clearance. So cystic fibrosis, and then you want to help someone. In cystic fibrosis, you basically have fibrous tissue in the lungs. Normally the lungs have got elastic tissue. Now if the elastic tissue is substituted by fibrous tissue, that is a problem because the fibrous tissue is not elastic for the lungs to be able to expand and come back together like that. So precautions when you're using mucolytics, asthma or a history of bronchospasm, okay, as you give these. So IV administration or inhalation may result in acute bronchospasm or anaphylaxis. In as much as we've said you give them in conditions that where there is obstruction, but make sure that you take precaution because they can result in bronchospasms or worsening of the condition. Okay, because of anaphylaxis of hypersensitivity. And then in respiratory insufficiency, inadequate cough mechanism or gag reflex depression, liquefied pulmonary secretions can occlude the airway. The thing is that remember when you give these drugs, it will basically thin the mucus. It becomes more liquid so that we can remove it. But someone can't cough. If this one person doesn't have the capacity to cough and then you give them these drugs, what will happen is that it can end up getting to occlude the airway. and that can be bad. And then for the expectorants, these ones they will increase the volume and decrease the viscosity of bronchial secretions. Take note of that, increasing the volume and decreasing the viscosity. So secretions can be more easily and cleared by the mucociliary system and by coughing. So an example of a drug which is an expectorant is guaifenesin. It's the only agent that is approved for use as an expectorant, guaifenesin. So it offers little clinical benefit for patients with obstructive lung disease. So adequate fluid intake therefore is more effective. Some side effects include dry mouth, chapped lips, risk of kidney disease or kidney stones because there is high risk of increased uric acid excretion. When the uric acid is being excreted, can end up precipitating forming these stones. So take note of that. So guaifenesin itself is commonly combined in the cough syrup. Okay, like those toma, it's something that is sweet. You know, cough syrup. If you remember when you are a child, you're having a cough, they give you this nice drink which is so sweet. That's the cough syrup. So you are going to find guaifenesin there for the symptomatic management of productive cough associated with upper respiratory tract infection, like someone has got pharyngitis, bronchitis, influenza, measles, or cough provoked by sinusitis. So it can help. Remember, it is a wet cough or a productive cough. It is also common used in combination with cough suppressants like dextromethorphan. Take note of dextromethorphan. This one suppresses cough, it stops cough. But remember the expectorants, these ones will basically increase the volume and then get to reduce viscosity. So why is it combined with a cough suppressant like dextromethorphan? To reduce dry cough, to reduce the dry cough, while loosening mucus in the respiratory tract to allow for productive cough. Okay, so if someone has got a dry cough, the cough suppressant can be used. And then you can also loosen the mucus in case you have got a productive cough. So for a non-productive cough, that's the dry cough, you can use a cough suppressant. And then pro, for a productive one where it is wet, you can now give these expectorants to allow for productive cough. Basically, in other words, it's more like you're trying to convert the non-productive to productive. You thin the mucus. Once you thin the mucus, and then it can be removed from the body. So expectorant should not be used for self-medication for persistent or chronic cough such as those associated with smoking or COPD. So don't use these guys for persistent or chronic cough associated with smoking or COPD. Persistent cough may be indicative of a serious condition. So if cough persists for more than a week, or is recurrent, it keeps on coming back again and again, or is accompanied by fever, or if it's accompanied by fever, that would mean probably there is an underlying infection. So just consult for more advice. So side effects of guaifenesin, they are not really serious. It includes on the GIT, nausea, vomiting, and diarrhea, and then on central nervous system, drowsiness, dizziness, and a headache. Precautions or contraindications for expectorants: persistent or chronic cough, you don't give them. Some asthmatics are prone to bronchospasms. You should give them these drugs. Cardiovascular disease and hypertension, you want to avoid them. Diabetics, people with glaucoma, hyperthyroidism, prostatic hypertrophy, especially with combination products, and pregnancy or lactation. So they are not good because they can end up crossing to the baby. And then for the antitussives, which we also call as the cough suppressants. Antitussives are drugs used to stop or reduce cough by acting either primarily on the peripheral or the central nervous system component of the cough reflex. Okay, basically trying to stop the cough itself. So cough suppressants are indicated for patients with persistent, fatiguing, non-productive cough and pain. For example, pleuris and fractured ribs. So that cough that is persistent, it is tiring, it is dry, and there's also pain. Okay. So opioid agonists, for example, dextromethorphan and hydrocodone are potent antitussive agents. When we are discussing the opioids in pain management in neuroscience, we had mentioned this, okay, that they most of them have got an effect on the cough reflex. So take note, these are actually opioids, dextromethorphan and hydrocodone. The mechanism of action is direct suppression of cough reflex at the cough center in the medulla. So indications and side effects, these antitussives are used for inflammatory, non-infectious tracheal and pulmonary diseases during invasive diagnostic techniques such as endoscopic examination and bronchoalveolar lavage. You are trying to treat someone, so you are passing an object through their mouth or through the nose so that it goes into the GI. So don't want them to end up coughing when you are doing that. So what you do is you can give them these cough suppressants, and then opioid agonists may increase the viscosity of respiratory secretions and produce sedation and constipation. Those are side effects. Remember, the others, the mucolytics and the expectorants, were decreasing viscosity, but these ones can end up increasing viscosity and end up increasing secretions, and they can produce sedation, like to just depress you, and then someone is low, okay, and they can cause constipation. So cough suppressants actually divided in two. For these ones, the mucolytics are divided in two, not the mucolytics, but the antitussives are divided into the peripherally acting, those that suppress different stretch receptors on the peripheral, like on the respiratory system itself, and the opioid and non-opioids, or the narcotics and the non-narcotics, which suppress the cough center in the brain. So for the narcotics, you have got codeine and hydrocodone. The non-narcotic, you have got dextromethorphan. Okay, these ones will basically suppress the central nervous system. The peripherally acting will basically work on the stretch receptors that cause a cough to start. So the peripherally acting antitussives, these ones are inhibitors of airway stretch receptors. In the pharynx, you can use demaucent, which is forms a protective coating. It is given as a soothing pastille or lozenges, if you've heard of this one. Okay, it's a common one that's given, the lozenges. Someone is having this cough, it will actually help you to relieve also pain in the airways. And then also gargles and the syrups of acacia. Okay, so all these will work in the pharynx. And then in the larynx, you use emorients. So in the pharynx, it was a demaucents. In the larynx, emorins, which form a protective coating, and they are given also as a syrup or soothing spray, or for menthol and eucalyptus. And then in tracheobronchial airway, you use aerosols or inhalation or hot steam alone, or medicated with the tincture, benzoin compounds, and eucalypto. It's not like something that you should really master like that. And then during bronchoscopy or bronchography, when you are trying to use an instrument to go through the bronchioles, so you use local anesthetic aerosols like lidocaine, benzocaine, and tetracaine. So these are anesthetics, they stop pain, and then they can also get to suppress these uh, cough. Okay, so those are peripherally acting, which inhibit airway stretch receptors. And then you can also have those that inhibit pulmonary stretch receptors in the alveolar. This one is specifically in the alveolar. We have got benzonatate, okay, which is also known as a tesalon. This one will be able to reduce sensitivity of receptors by local anesthetic action, and they also have a central inhibitory effect. So they are given orally as a soft gel capsule 3 times a day. The capsule must be swallowed intact in order to allow slower release of the medication, being potent and toxic. So the adverse reactions includes drowsiness, dizziness, dysphagia, pain when swallowing, allergic reactions, and then for overdose, it can lead to mental confusion, hallucinations, restlessness, and tremors. So just take note, you have got these that inhibit the airway stretch receptors and then also in the alveolar. Maybe just no examples. Okay. Of course, these are common the lozenges which we buy in the shops. If you have got a cough, just go and buy the lozenges you'll be able to buy in pharmacies. And then for those that act centrally, these are the opioids, okay, like codeine, which is methylmorphine, and the 4-codeine. And then you also have morphine itself, which is only in bronchogenic carcinoma because of its many side effects. So you barely use morphine because it has got a lot of side effects. So opioids, those used have less addicting and more antitussive and less analgesic effect, because opioids are also used to stop pain and they are more or abused because they cause euphoria. So those that you use here should be the ones that have got more antitussive effect than analgesic and addictive. For example, codeine, hydrocodone. Okay, and they act direct on the cough center in the medulla by inhibiting the release of excitatory neuropeptides via activating the mu opioid receptors. The adverse reactions for this includes constipation, inhibition of mucociliary clearance, so the thick sputum, so there will be inhibition of the thick sputum from being cleared, and then drowsiness, mild respiratory depression, dependency, because remember these are opioids, and dry mouth. For the non-opioids, dextromethorphan is a common one, or histamine 1 blockers, which are better. For example, they are better sedating. For example, diphenhydramine and chlorpheniramine. But what is just important is no dextromethorphan. And of course, we can just say H1 blockers. They can also be used because for the cough reflex, histamine is also going to play an important role for cough. Okay. So for the non-narcotic antitussives, these, remember we said, so those are actually narcotics. The non-narcotic is dextromethorphan. So then these ones are narcotics. Please just change there. Codeine is a narcotic antitussive which is widely used as cough suppressant with reduced incidence of side effects compared to morphine. So there is less respiratory depression and bronchoconstriction when you are using codeine. Hydrocodone also can be used, but it is more sedating. It can depress the central nervous system. Okay. So the recent change from drug enforcement administration, hydrocodone is prescribed less frequently as an antitussive. It's more sedating. Okay, so those were the narcotics. And then for the non-narcotic, we have got dextromethorphan, which is used more frequently because they do not depress the respiratory system, they don't cause dependence, and they have got less side effects at recommended doses. So dextromethorphan should not be used in patients under the age of 4 because of the cough center in the brain is not fully developed and the similar antitussive effects. It has got similar antitussive effect as codeine at the same dose. You also have some other drugs like the benzonatate, which is chemical related to the local anesthetic tetracaine. It also acts centrally, like the other antitussives, to suppress cough. Okay. You also have these others like diphenhydramine, which is a first generation antihistamine used as a cough suppressant. Patients experiencing a cough associated with common cold or postnasal drip can be given this first generation antihistamine. Okay. F- This first generation this diphenhydramine is used as a first generation antihistamine and a decongestant to treat cough. Okay, decongestants. The side effects of the antitussives generally respiratory depression, constipation, sedation and dizziness, nausea and vomiting, and also urinary retention with the narcotic antitussives. Precautions when you are using the antitussives: addiction prone patients, when you are using narcotics, should be you should take precaution because they can end up worsening that, or you are giving someone that abuses them, they can end up continuing to take them even when they don't need them. Chronic obstructive airway disease also should be able to use this precaution. Concurrent use with other central nervous system depressants because they can actually add up and depress more. Use of cough suppressants in coughs associated with upper respiratory infection are not recommended due to limited efficacy. Okay, so want to give for you want to not give really with someone that has got an upper respiratory tract infection because they will not be able to work more. And then caution for intrusive in children, as we said, the respiratory system is not fully developed. Okay, so that is basically it. And then here is a question: an 18-year-old met three students as a dry cough for 2 days with no fever but slight headache whenever he coughs. He buys an over-the-counter cough mixture to stop suppress the cough and allow him to sleep at night. Why do we cough? Name two side effects expected from most cough suppressants. What is the most effective medication for suppression of cough? Remember, this one is a dry cough. What oral gel capsule is used for cough suppression? What is the mode of action? And then the second, the student notices some white sputum after 2 days of treatment. His friend in Med 7 tells him to get a mucolytic or expectorant cough mixture. What is a mucolytic and its indication? What is an expectorant and its indication? So it's basically the same patient. So that is it for this one. You can get to try out those two questions. We see if you can answer them.